This program is brought to you by Emory University.
Morning, everyone, and welcome to another Heart and Vascular Grand Rounds. It is my pleasure to introduce a friend and a colleague today, Dr. Alexis Cutchins. Dr. Cutchins went to Hamilton College for undergraduate, followed by medical school at Emory. She did her residency at Weill Cornell in New York, followed by an NIH research fellowship with her clinical cardiology fellowship at the University of Virginia. And she joined Emory in 2012. She served as the director of the anticoagulation clinic at Midtown and currently serves as the echo director there. And recently, she received the Department of Medicine Outstanding Clinician Award. Over the past 10 years or so, Dr. Cutchins has really been focusing on developing her expertise in the patients with POTS. As we know, these are very complex patients with lots of problems, and she's really developed a true expertise in this area with taking care of patients with dysautonomia and particularly long COVID. I know that I have sent several patients to Dr. Cutchins. I know that a lot of my colleagues also here have. And we really, she's been thinking about these patients. She's been reading about them and has some innovative ideas. She's recently been publishing in this area and has presented at AHA and ACC. And I'm really looking forward to this talk so that she can teach us what she's learned by just taking care of these patients in her very, very busy clinic. So Dr. Cutchins.
Thank you, Pooja. I appreciate the invitation and I appreciate the opportunity to come talk to all of you about what I'm seeing in this challenging population of patients. As you all know, it's not easy taking care of them, but it's quite rewarding when they start to feel better, which is what I'm trying to achieve. So this morning, I'm going to talk to all of you about exploring a new path in the paradigm of POTS, venous and connective tissue disease as key contributors. Here we go. No financial relationships to disclose. What we're going to look at today is POTS in general, just a quick overview. I'm not going to spend much time on diagnosis and management, but we will review quickly POTS treatments. Lower extremity and pelvic venous disease is what we're going to concentrate on the most today, pathology, management strategies, et cetera. I have 2 patient cases to go over, and then I'm going to share some findings from our patients that are enlisted in our POTS registry that we started just about 10 months ago, I'd say, at this point. So what's POTS? Y'all probably heard some of this before from me, but I did want to highlight a recent review article that I wrote with 2 of our residents here that was published in September. This is a great overview for anyone who wants to learn more about managing and caring for these patients. It has a lot more details than I'm going to touch on in this talk this morning. So if you want to go online and take a look, that would be great. So it's the most prevalent form of orthostatic intolerance. It affects about 1 to 3 million Americans. Patients present in their teens to 40s, and they're more likely to be women than men in about a 5-to-1 distribution. There's been a significant increase in this population of patients since COVID and the long COVID sort of epidemic that we're experiencing right now. POTS is related to many different disorders and pathologies, autoimmunity, GI dysmotility, mast cell activation syndrome, small fiber neuropathy, connective tissue disorders, and hypermobility syndromes. Many of these patients develop POTS symptoms after infection or have long-term side effects from an infection, endocrine problems, and cognitive dysfunction, chronic fatigue issues, what we call brain fog in the long COVID world. So all of these interact with each other and influence POTS. They're not only interacting or contributing to POTS, but they're contributing to each other. So these patients have a lot of complicated medical issues, including POTS, which is what I see them for. But today I'm going to focus on venous disease and in this population of patients. I was going to start with this paper, which I found from 2002. that looked at quality of life in patients with postural orthostatic tachycardia syndrome. And I found it fascinating, actually. There were 94 patients, 89% of them were female, average age of 34. They were given the RAND San Francisco 36 quality of life questionnaire, and they were found to be significantly impaired in multiple areas of the questionnaire: physical functioning, role functioning, bodily pain, general health, vitality, and social functioning. 25% of these patients were disabled technically. But what they went on to look at was this cohort of patient in comparison to patients with heart failure and COPD diagnoses that they had stock survey results on in this population. So they looked at healthy women in the 25 to 34-year-old group. That was the light gray bar. Patients with POTS in black, patients with COPD in white, and patients with heart failure in dark gray. And what you can see here is that the patients with POTS are very similar to the patients with COPD and heart failure in terms of their quality of life. So there's a significant impairment there that is occurring in these patients that is equatable to what we see in our patients with heart failure and COPD. It's a heterogeneous disorder. There's a variety of responses to treatment. One medication may work for one patient, one medication may not. It could make the next patient feel worse. It's a very much of a trial and error process to manage these patients and to take care of them. And so it takes a lot of time and effort, for sure, but there's a lot we don't know, unfortunately. So the associated disorders that we see often are chronic fatigue syndrome, mast cell activation abnormalities, Ehlers-Danlos, the hypermobile type, which is type 3, and joint hypermobility syndromes, Raynaud's, migraine, pelvic venous congestion, and attention deficit disorder, PTSD, anxiety, and depression. These patients often have many of these things. So what are we seeing in these patients? I took this figure from a review article in the Lancet Neurology on orthostatic hypotension and management and treatment of orthostatic hypotension. You can see here that in the supine position, central blood volume is high. It's concentrated in the thorax, 30% of blood volume. When standing, about 300 to 800 milliliters of blood gravitate to the abdomen and lower extremities. 10 to 25% of this plasma volume shifts into the interstitial tissues when you stand. This is in normal people. You can imagine that patients with connective tissue disorders or collagen defects would have even more shift into their interstitial tissues. So this results in normal patients in a 10 to 15 beat per minute increase in heart rate and to 5 to 10 millimeter mercury increase in diastolic blood pressure. Now, I've augmented this picture a little bit to show a hypothetical further redistribution of venous disease. You can see that these patients could theoretically pool more blood volume in their abdomen and pelvis and more blood volume in their lower extremities if they have incompetent valves in their veins, if they have pelvic venous disease and pelvic venous congestion. So this is what I'm going to try to argue today, that these patients with POTS have venous abnormalities that are causing more pooling than the average person, and that's causing a reflex tachycardia. So what do I do when I see these patients? I evaluate them for hypermobility using the Baton score. I look for venous pooling and edema on exam, which I see in almost every patient, elasticity of the skin, and pectus abnormality deformations. So the Baton score is used to diagnose hypermobile Ehlers-Danlos. It's a constellation of sort of maneuvers that we do in clinic to look for hypermobility in these patients. It's very simple to do. Actually, it takes under 30 seconds for me to have my patients do this. The only complication when doing these maneuvers is asking them to bend over and put their hands on the ground, because when they stand up, they obviously get awfully dizzy. And so I make them sit right back down again. I haven't had anyone pass out in my clinic from these maneuvers yet. I'm sure it'll happen someday, but so we look at all of these to see, are their elbows hyperextended, are their knees hyperextended, et cetera. I look for venous pooling. This is an image of a patient during a tilt table test. You can see venous pooling here while standing, that resolves in the supine position. This sort of ruddy Erythema is what we see. I see it in clinic after talking to these patients for 20 or 30 minutes. When I look at their feet, they're usually purple, red, bluish in coloration, and it blanches. So if you push on it, it turns white. Clinically, these patients have many symptoms: fatigue, brain fog, fainting, chest pain, shortness of breath, palpitations, pain, pretty much all over, but they do endorse leg pain, lower back pain, pelvic pain. Heat intolerance is huge. They have light sensitivity and sound sensitivities as well. So there's a lot going on with these patients. They have many symptoms. Symptoms usually start after a life stressor. So we're either a traumatic event like a surgery, a death of a loved one, or a viral infection, for instance, COVID, but also we see this post-Lyme disease, post-EBV infection, mono, et cetera. Symptoms can wax and wane or be very persistent and are aggravated by exercise, postprandial state, carbohydrate intake, menstruation, and heat. I would argue this number is, taken from the literature as 15% for menses, but I would say that's much higher than that. To diagnose, we look for an increase in heart rate going from supine to standing position of greater than 30 beats per minute, or an increase to 120 beats per minute within 10 minutes of tilt or orthostatic challenge. There's usually no orthostatic hypotension. In fact, sometimes we'll see the blood pressure go up. Oftentimes I see the blood pressure go up. Many of my patients don't necessarily have this change in heart rate, but they come into my office with a resting heart rate of 110 beats per minute, and it goes to 120 when they stand up. But some of these patients really just live at in a tachycardic state. Many patients with POTS are thought to have panic disorder, somatization, anxiety. It's not uncommon to see patients and have them tell me that they were happy I didn't tell them it was all in their head and that they were making these symptoms up. So it's due to the vague symptoms and systemic complaints, and recognizing this diagnosis in these patients and validating their concerns is really the first step in their care. So how do we treat? This is just a little overview. We increase volume with fluids and sodium. No matter how much fluid you drink, if you don't have enough salt, you're not going to increase the intravascular volume. Compression to the waist is best. I encourage patients to wear compression to at least the thighs or higher, 20 to 30 millimeters of mercury. I add medication: fludrocortisone, midodrine, DDAVP. These are just some. Beta blockers, ivabradine, SSRIs. It's really sort of a trial and error situation, as there aren't significant randomized controlled trials demonstrating that specific medications in these patients work. And that's because of, like I said, the heterogeneous nature of this disease. Not everyone responds in the same way to each medication. And oftentimes these patients have adverse reactions to medications. And so it's hard to find the right one that they don't react to. Exercise is key. Once these patients can start exercising is tolerated. It's the most important thing for them. Slow titration, recumbent position to start. And this is all, we go over all of this in the review article that was recently published, if you want to take a look at that. So let's dive into connective tissue disorders and hypermobility a little bit. Hypermobile EDS type 3 is diagnosed based on clinical presentation, family history, and physical exam. There's no genetic marker, although there are groups that are working on a genetic marker for this disease, and hopefully that will emerge soon. It's not the same as vascular EDS, because we know that vascular EDS has arterial complications, and these patients don't normally have that. But it's a disorder of connective tissue and collagen specifically. It's a collagen defect that causes their hypermobility to occur. Patients with hypermobile EDS have notoriously difficult blood draws. Venous access is very challenging for them. Their skin is stretchy and thin, and they account for about 90% of all EDS patients. They do develop venous disease, and many of these patients come with venous compressions at the skull base and in the pelvis. And in addition to venous compressions, they also have arterial compressions in the abdomen, like median arcuate ligament syndrome and SMA syndrome. But there's a spectrum of disorder here. They don't all have EDS. There's patients with frequent joint dislocations or frequent popping and cracking of the joints. Lipedema is something I see often in my clinic, where there's abnormal fat distribution in patients after stress. This is usually not related to their diet or exercise habits. This is related purely to sort of a stress response in their body. Excessively stiff joints is something that I see as well. Patients can have extremely stiff joints, but all of these seem to be related to an overarching theme of a defect in collagen, and that seems to override all of their all of these features. So there's a significant overlap between symptoms of POTS and symptoms of pelvic venous disease and lower extremity venous disease. And I'm going to review venous disease now for everyone, just to get an idea of what I'm talking about. We're going to go over normal veins, what happens with varicose veins, conditions like venous insufficiency, iliac vein compression, and renal vein compression. So the normal anatomy of the venous system in the lower extremities consists of superficial and deep veins. The superficial veins have valves that help move the blood flow back up to the IVC and help prevent venous pooling. The deep veins then drain into the iliac veins and the IVC to return blood flow to the heart. Normally, when muscles contract in the legs, the muscles push blood up into the venous system and against gravity, and the valves in the veins prevent blood from falling back down. Okay, and that's the normal system, and this is how we move blood that's pumping continuously to our feet back up to the heart. When there's obstruction, you can get dilation of these veins, varicose veins. The dilated vein has less competent valves, and so when the muscles are pumping, you have venous return instead. You have venous pooling, so blood will fall the wrong way or will pool, and so this is what causes edema in the lower extremities and venous pooling. Patients with venous insufficiency have aching, heavy, crampy, and uncomfortable legs. They have swollen feet and ankles, burning, throbbing, or tingling sensations in their legs. A lot of my patients suffer from a quote unquote neuropathy, and I think this is just the symptom of their venous disease, to be honest. Muscle cramps in the legs, particularly at night, dry and itchy skin over the affected veins, and pain that worsens with standing position and improves with supine position. So pelvic venous disease, what's this? There's two pelvic compression syndromes that I'm going to touch on today. The first is iliac vein compression, or May-Thurner syndrome. May-Thurner syndrome is the pathology that occurs when the right iliac artery compresses the left iliac vein, as seen here. You get dilation of that left common iliac vein and backup of flow, which causes congestion in the pelvis. You can see here in an axial view, this is the right iliac artery compressing that left iliac vein as it comes across the spine. In MRI, this is an MRV of a patient of mine, and you can see here, similarly to the diagram on the previous slide, that this is the left common iliac vein that's compressed by the right common iliac artery. The right common iliac vein is large and open. That's what the left common iliac vein should look like, but it's compressed here. If you look at this with a venogram, you see the left iliac vein here, and there's a flow stoppage of blood flow. This is caused by the right iliac artery. These are collaterals that form so that blood can flow back to the heart. So there's cross pelvic collaterals that take blood flow across the pelvis back to the right common iliac vein. And there are paraspinous collaterals. And I have several pictures of these venograms in my talk, so you'll see this multiple times. What you can do is sort of superimpose the vision of the aortic system on top of the venous system here in this patient. If you imagine the right iliac artery coming across here to go down to the right leg, you can imagine how that compression could be causing this obstructed flow. So it's classically described as a rare thrombosis of the left iliac vein in the setting of right iliac artery compression. Symptoms can include swelling, heaviness, or fullness in the leg or foot, venous ulcers or sores that don't heal on the leg, varicose veins in the leg. The syndrome itself is is, described as leg pain and swelling or thrombosis at that site. It can be either. Nutcracker or left renal vein compression is another syndrome that we see in these patients. It's entrapment of the left renal vein between the abdominal aorta here and the superior mesenteric artery here. In patients who lack adequate connective tissue disease, who lack collagen in the vein walls, they develop this collapse of the left renal vein here when the artery, the SMA compresses the vein against the aorta. This results in dilation of the left renal vein and of the gonadal veins. And when the gonadal veins are dilated, they develop varicosities. In men, they develop a varicocele. In women, this is ovarian varicosities that sit in the pelvis and pool and cause pain. Anecdotally, many of my male patients that have come to see me for long COVID have a history of varicocele, which I find interesting. And I've only just started asking patients in the last year, but I would imagine it's much higher than the general population. So symptoms from Nutcracker include hematuria, can be microscopic and intermittent, orthostatic proteinuria, left flank pain, abdominal pain, the varicocele and pelvic congestion, as I mentioned, pain with intercourse, pain with menstrual periods, fatigue, and orthostatic intolerance, which is described pretty extensively in the literature, actually. If you combine Nutcracker syndrome and May-Thurner syndrome, you can get sort of this syndrome of pelvic venous disease, which is pelvic venous congestion. And historically, that was described as pelvic pain that's worse in the upright position. Many of my patients tell me that over the course of the day, their pelvic pain gets so bad that they can't stand anymore and they have to lie down. And once they lie down, that pain improves. Pain with urination, frequent urination, incomplete emptying or urgency. These are all symptoms of interstitial cystitis. These patients feel like they have chronic urinary tract infections, but they don't actually have bacterial infections. They have inflammation of the urinary tract. Low back pain and hip pain, also dependent over the course of the day, gets worse while standing and sitting and better while supine. There's varicosities of the upper thigh, the vulva, the labia. What's interesting is that there was a publication in 1945 that sort of described this syndrome, and there they also reported tachycardia, palpitations, and severe fatigue, which is obviously very much overlapping with my population of patients with POTS. So there seems to be some association in the literature between orthostatic intolerance and Nutcracker, not as much with May-Thurner, but I think it's just has not been explored. The association between pelvic venous disease and orthostatic intolerance is certainly emerging. So transitioning into this case series that I thought was a great example of what I see in my clinic every day. Dr. Taub published this in 2021, a case series of 3 patients with May-Thurner syndrome who had postural orthostatic tachycardia and Ehlers-Danlos. Two of these patients ended up getting stenting to their iliac vein and improving symptoms. The third did not, had been contemplating stenting at the time of this publication, but other people are seeing this. So that's great. After that, Dr. Smith, who's been a big advocate for patients with pelvic pain over the course of his career, he's recently retired, but he has seen many patients with chronic pelvic pain that have not resolved with hysterectomy or treatment of endometriosis, but do resolve with treatment of their pelvic venous disease. He started to realize that there was association between dizziness, tachycardia, palpitations, and in these patients, because when he treated their pelvic venous disease, he noticed that these symptoms went away. So he looked at this first study he did was looking at CT scans of patients with POTS, CTA or CT with IV contrast to evaluate their iliac disease. As you can see here, this is the method they use to measure the iliac vein, the left iliac vein below the right iliac artery. And what they found was in 191 patients with POTS who had a CT in the past, this was a retrospective, 69% of them had compression of their left iliac vein. They compared this to age-matched healthy female controls who were donating a kidney for renal transplant. And in that population of patients, these independent radiologists who reviewed these studies noted 40% of them had iliac vein compression. So it's not non-existent. The question is, does this population of patients of normal, healthy female controls actually have symptoms that would be indicative of pelvic pain, like or pelvic venous disease, like pelvic pain, heavy menstrual periods? A lot of these people have migraines, tachycardia, obviously, and dizziness. But so we don't know, but the healthy controls, there's about 40% compression. They postulated in this review, in this article, that the reason why these patients develop tachycardia and the sympathetic response is because of the venous outflow tract obstruction and pooling. There's extremity blood pooling that decreases the cardiac venous return. It inactivates the baroreceptors, and then you get the sympathetic response of tachycardia, also anxiety and a tremulous state. They then went on to publish another paper that looked at survey results from a pelvic venous congestion support group. So they went to Facebook, they found a support group of patients who all had diagnosed pelvic venous disease, and they sent them 2 surveys. The first survey was asking if you've been diagnosed with any of these other conditions. So we already know they have pelvic venous disease. They were asked if they have any of these other diagnoses: POTS, irritable bowel, chronic fatigue, Ehlers-Danlos, interstitial cystitis, fibromyalgia, and endometriosis. And what they did was they compared this to the general population. And you can see that there was a higher prevalence of patients in purple that have been diagnosed with pelvic venous disease versus the general population for POTS, IBS, chronic fatigue, Ehlers-Danlos, and endometriosis. It was pretty significant. They then went on to ask these patients if they had symptoms of these problems. So not necessarily a diagnosis, but just, do you get dizzy? Do you faint? Do you have heart palpitations? How is your fatigue level, energy level? They asked specifically, do you have severe chronic tiredness that limits activity, and so on. So if you look at this in table form or graph form, you can see that over 60% of these patients had symptoms of dizziness. Over 70% of these patients had symptoms of chronic fatigue. Over 60% had symptoms of irritable bowel. And then also dysuria and interstitial cystitis symptoms, migraines, jaw problems, which is related to the connective tissue underlying disease, and Ehlers-Danlos. Many of these patients have TMJ and joint issues, jaw issues. And then excessive sweating as well, which is an autonomic response. We're having a little fire drill here in the lecture hall. I'll just keep going. So there's limited data on the association of orthostatic intolerance and iliac vein compression and renal vein compression, but more studies clearly need to be done. So how do we treat this? This has been a question that I've been asking myself a lot these days, and I've been trying to figure out the best way to treat these patients and to manage this disease for them. One thing I came across was a supplement that had a very small randomized controlled trial, diosmin. It's a flavonoid, and they used this in patients with chronic lower extremity venous disease to treat venous insufficiency. And they showed here actually that after 4 and 8 weeks of treatment with this drug versus placebo, there was a significant drop in calf circumference. And so their leg size dropped after using this supplement. It was a small population, so who knows, but interesting. And as far as medical management of lower extremity venous disease, for nutcracker syndrome, the medical management is an ACE inhibitor and an aspirin. And obviously, as you all can imagine, using ACE inhibitors in my population of patients is hard, but some of them do have high blood pressure, and I can do that. Weight gain seems to help alleviate some of the pressure of the SMA against the left renal vein. Renal vein stenting is an option, although poorly tolerated, and it doesn't seem to be very much in favor these days. And then autologous renal transplant or renal vein transposition. Some patients actually donate their kidney on the left side to remove this obstruction, so they just keep the right kidney. There are several papers that have looked into this. This is a nice review of all of the studies done on medical management of nutcracker syndrome, and they basically all used a combination of some sort of anticoagulation and aspirin, ranging from low molecular weight heparin to DAPT in these patients, followed by first for a period of time, followed by aspirin use. And the clinical improvement was pretty substantial in this population. When they're looking at clinical improvement in these studies, they're looking at hematuria and left flank pain. That's it. They're not looking at any other comorbidities. This study looked at laparoscopic placement of left renal vein extravascular stenting, and they had some good results, 76 patients. There was no open conversion in the surgery, and many of them had complete symptom resolution. Some of them had significant symptom improvement. Only 2 patients out of the 76 reported no symptom improvement whatsoever. And I think this is useful information, because I think a lot of people bias this population of patients as those that would maybe have a stronger placebo effect than others. I don't tend to agree with that statement, but there were patients in this population, in this cohort, that did not feel better. So, you know, it's not, I don't think it's all super tentorial. I do think that there is improvement in symptoms here. So there's been, you know, there's value maybe in renal transplant and endovascular stent placement in these patients. There's some risk involved with each method. The management of Nutcracker has not been really substantially reviewed, and seems to be very site dependent and very much dependent on certain centers that actually specialize in this. But now they're looking at some urinary markers to see if patients would benefit from surgery on the left renal vein. And so there's more to come here in this realm. As far as iliac vein compression is concerned, iliac vein stenting has been shown to be safe. There's also sclerotherapy, or coiling of the gonadal and gonadal veins, so the dilated varices in the abdomen pelvis that people use to help treat symptoms as well. So just, you know, to review a couple articles on iliac vein stenting, this retrospective review of patients with May-Thurner syndrome from 2006 to 2010 looked at 2 groups of patients, 56 in the post-thrombotic state and 21 in a de novo presentation of chronic swelling and pain or ulceration. 78% of them had left-sided symptoms in group 1 and 79% in group 2. So not all of them had isolated left-sided pain. And often I see in my patients, actually, they have pain and swelling in the left leg to begin with, and then it develops in the right leg and it becomes more bilateral. I think as those collaterals form and as the body compensates for that compression, there's elevated venous pressures, and that elevated venous pressure develops on both sides instead of just the left. But the patency rate for these stents was good. At 36 months, 91 and 95% for primary and secondary patency rates in group 1, and that 91 and 91% in group 2. Circulation Cardiovascular Interventions published this meta-analysis, which was also useful. They looked at 37 different studies encompassing the realm of iliac vein stenting in 2,869 patients total. They distributed these patients were both non-thrombotic and acute thrombotic or chronic post-thrombotic patients. And the success rates in these groups range from 94 to 96%. Complications of peri-procedural mortality were 0.3 to 1.1%, and early thrombosis 1 to 6.8%. At a year, 99% of patients with the non-thrombotic disease were the numbers for primary and secondary patency rates, 87 and 89 for acute thrombotic, and 79 and 94 for post-thrombotic. So these stents stay open. When they close, there's clearly increased risk of pulmonary embolism or other manifestations. However, I think that the closure is not just thrombotic, it's also from compression. So if you really have a socked in iliac vein by that right renal artery, then we may not be able to keep that vein open with the stent. So overall, it's a low risk procedure. The risk of complications is roughly 0.5 to 4%, although it's hard to say. There's back pain with this procedure. These patients have Lower back pain, that's new and different, and it comes on after placing that stent, and it usually lasts anywhere from 24 hours to 2 weeks. They can also get a SIRS-like response. It sort of reminds me of what I saw in the initial days of TAVR when we opened up the aortic valve and all these patients were in the ICU with SIRS. Now they're doing okay. We seem to not have that problem anymore. I'm not sure what changed, but these patients seem to get a similar sort of hyperinflammatory state post-stent that resolves. So, and this is just an example of a patient with the left iliac vein compression here. Again, the cross pelvic collaterals and paraspinous collaterals. And after stenting that vein, the collaterals all disappear. And that's because flow is now being shunted in the proper direction. And we don't have the collateral flow or the need for that. And those veins end up, scarring down or just collapsing and not being used, which is great because then patients aren't pooling blood in those areas. So what do we know about the treatment of venous disease and autonomic dysfunction? Well, nothing. This is something that I'm interested in that I don't know, there are not many other people in the country looking at this, but it seems promising to me that there could be a method to treat these patients non-pharmacologically to help improve their quality of life and their functionality. There's no current indication for venous stenting or lower extremity ablations in orthostatic intolerance, and we have no idea what the extent of clinical benefit for these patients is. Restoring venous return, however, and limiting pooling seems favorable in this population of patients. To me, it just makes sense that if we can prevent pooling and prevent this lower extremity edema and pelvic pooling and congestion, we can help patients get better venous return, improve their cardiac output, and improve their quality of life. So there are concerns about interventions, which are very real. Patients with mast cell activation syndrome are very reactive. Many of my patients have allergies to just about everything, and including metals and other parts of stents potentially. And so there's concern there. Stent embolization has been a concern, although with the newest Aubrey stents, it seems to not be as much of an issue. Stent thrombosis, also with the newest stents, does not seem to be as much of an issue. Infection risk, worsening symptoms, these are all question marks that we don't have good answers to. But I'm going to tell you about two patients that I've seen in the past and give you their stories so that you can get an idea of what I see in my clinic and how this is relevant. The first patient is a 25-year-old Caucasian female with POTS. I started seeing her many years ago, and she told me she could only eat 4 foods. If she had anything else, it would disrupt her GI tract. She wouldn't be able to function. She got severe nausea and vomiting. And she couldn't tolerate any pharmaceuticals because they all gave her serious psychiatric side effects. And this is, suicidality, psychosis, real problems for her. So she refused medications. Her POTS symptoms have been managed quite well with fluids and lower extremity compression. And she tolerated this. She was doing great. I saw her for a couple of years with this strategy. She was happy to continue that way. But at one point, the compression no longer worked for her. And she was suffering with symptoms and she couldn't perform her job. I suggested we look at her lower extremities to see if she had venous insufficiency. And we found significant lower extremity venous reflux. The patient met with vascular multiple times. She had long conversations with them, and her family had long conversations with them. They had no idea, what to make of this venous disease and of the risk of GSV ablations bilaterally. But ultimately, she felt that the benefits from the possible benefits that she could accrue from this would outweigh any risk. And her quality of life was so poor that she underwent bilateral GSV ablations. And several months later, when I spoke to her, she told me that her symptoms had completely resolved and she no longer needed to see me in clinic, which is true. I have never seen her again. This was all over the phone because she wouldn't come back. She works in door-to-door sales. Her brother went to the same vascular surgeon to have the same procedure done because she was feeling so well. He also had an excellent result and felt much better after these venous ablations. We have just recently accepted, there's a case series of 4 patients of mine who underwent GSV ablations for management of their lower extremity symptoms, but with improved POT symptoms. And that should be coming out shortly, if you want to look at that. But this was really encouraging for me because I now had something that I could look for and possibly treat in these patients who would not tolerate any medications and who really had adverse reactions to medications. So I started looking for lower extremity venous disease. It turned out that some of these patients that I looked for this in and that we treated didn't do as well. I mean, obviously, right? So we have extremes and she was one extreme. But then I started asking the question, why? Why are some patients doing great after just doing an ablation of their lower extremities veins and other patients are not? And what I found was this phenomenon of May-Thurner and the fact that no matter what, if you don't fix that more proximal obstruction, you're going to continue to have venous disease in lower extremities because of the venous hypertension that occurs from that obstruction. So this is a patient that I've been seeing for the past year or so, KM. She's 22 and she has a history of Tourette's and POTS. She had many symptoms, including seasonal allergies and dysphagia, which are sort of mast cell symptoms, bilateral leg pain and pelvic pain, pain with intercourse, joint hypermobility, severe chronic fatigue, and depression. On exam, when I saw her for the initial visit, her heart rate went from 63 to 101, going from supine to standing in the office. She developed tunnel vision at that time and presyncope. I started her on antihistamines, which I do in a lot of my patients, given their sort of allergic history. And her labs showed low magnesium and elevated norepi levels. She had venous disease in the bilateral lower extremities, and her pelvic ultrasound showed May-Thurner syndrome. She was intolerant of many medications, SSRIs, beta blockers. She didn't tolerate florinephromidodrin. She was so depressed at one point that she couldn't take care of herself or consistently take any medications for that matter, whether she tolerated them or not. She couldn't adhere to any kind of regimen that I was giving her. So here's an image of her ultrasound. It shows the left common iliac vein here compressed. This is the spine. This is the right common iliac artery. You can see it here without color flow, but there's a nice depiction of that compression. On IVUS, intravascular ultrasound, you can see this left common iliac vein is compressed as well, below the right common iliac artery. And this is the spine. And then this is just for reference, the normal common iliac vein without compression in this patient, the normal segment. She had a venogram that showed both paraspinous collaterals and cross-pelvic collaterals, as you've seen in previous pictures, and after stenting had an excellent result. What was great was that when I reached out to her after her stenting about 6 weeks later, she said she felt great. She'd been playing pickleball and becoming more active. Her appetite was back and she was able to eat more. Her mental health improved. She'd been crying tears of happiness since it felt like she had her life back. No more painful heavy limbs, severe fatigue, dizziness, loss of vision, or other symptoms. I can stand up or jump up and run around and I feel perfectly fine. It's the best I have as long as I can remember. So this is, again, another fantastic result. You know, this woman went from being essentially bedbound with depression and not being able to take care of herself now to going out and socializing, playing pickleball, et cetera. So I was very happy for her. So quickly, in the last 5 minutes or so, I'm going to just talk about what we see in our clinic and what I've been finding in these patients, what we're trying to study and publish. So it's estimated that the incidence of venous disease or venous insufficiency in the general population ranges from anywhere from 7 to 60%. There's a wide range. Most common findings in the literature is about 40%, and I would say that's what's accepted by most. Similar for iliac vein compression. On autopsy results, they see about 40% with iliac vein compression. So we looked at 130 patients evaluated with lower extremity venous Doppler who had presented to my clinic for POTS, orthostatic intolerance, long COVID, et cetera, or who were existing patients in my clinic. The average age was 35, 89% female, and 75% of them had a diagnosis of superficial venous insufficiency. 53% with bilateral common vein reflux, deep venous reflux. I think this is a large bump up from the average general population of 40%. And these patients range from 16 to, their 50s or so. So it's not just older women, it's young women, an average age of 35. We could be underestimating this because these patients often showed up NPO or not adequately prepped for the lower extremity venous Doppler. And so it may actually be more. We also looked at 94 patients who were evaluated for pelvic venous disease. This was submitted to the ACC meeting. They were the same population of patients. 21 of them were excluded because their workup for pelvic venous disease had not been completed, but 56 out of 77 or 77% had confirmed pelvic venous disease on imaging. And so that was pretty remarkable. In these patients, we looked at the symptoms that they presented with to clinic, and we reviewed their charts, and many of them had pelvic pain, lower back pain, lower extremity pain, edema, et cetera. So the 73 patients that we looked at, there's a high prevalence of urinary tract symptoms, of upper GI symptoms, and lower GI symptoms, which I think correlates to the prevalence of their pelvic venous disease. So we developed this POTS registry, and we've enrolled 191 patients, and they all filled out many surveys for us when they entered into our registry, which I very much appreciated. And just to look at the preliminary results of some of those surveys at the start of enrollment, out of 191 patients, 113 of them, or 59%, had right lower extremity edema, and 60% had left lower extremity edema. Pelvic pain was about 73% in this population. We also did the pelvic congestion syndrome survey, which was a pain scale of 0 to 10, and noticed that 63% of them had pelvic pain associated with standing or upright position. 35% of them had bulging veins in the buttocks, vulva, or posterior thighs, and 51% had painful leg veins and varicosities. So it's a large number. Just to show some very limited data about 16 patients who underwent iliac vein stenting for severe iliac vein stenosis. This was a mean age of 32, 100% female. We gave them the same survey that was given in the study that I discussed earlier in 2002, the RAND San Francisco 36 survey, to look at quality of life at baseline and at 8 weeks. The RAND 36 is validated quality of life survey. And what we found 8 weeks post iliac vein stent was, on average, every single quality of life category improved, with clearly large standard deviations and variability in outcomes. But if you look at their baseline on average and then their post stenting average improvements, you can see in purple the 4 to 6 weeks or 4 to 8 weeks out, their symptoms improved across the board, with, like I said, some more dramatic than others. On average, though, there was significant improvement in these patients. So how do I approach these patients with POTS and venous disease? Quickly, I treat them for orthostatic intolerance. I hydrate them. I give them salt. I use compression. I use many different medications in a variety of combinations. I treat mast cell symptoms, and I evaluate them for venous disease. For venous insufficiency, we look at lower extremity ultrasounds. And these studies should be done standing and in a well-hydrated state. For pelvic venous disease, the gold standard is venogram with IVUS. You can assess this also with MRV of the abdomen and pelvis. A lot of times when I send my patients for these tests, the diagnostic radiologists don't comment on the venous disease, even if asked. They hesitate to report those findings. I'm not sure why. So it gets missed unless you look at it yourself, or you have an experienced interventional radiologist or vascular surgeon look at those test results. CT often misses a large percentage, and ultrasound is a great screening tool that I use in almost every single one of my patients, but it's often missed. The venous disease is often missed. It screens, but it doesn't, it's not very sensitive. The first thing I do with these patients is try to get them on an oral contraceptive or other contraception program that eliminates their period. And I will say that when progesterone levels drop pre-menstruation, the vein walls relax and dilate, and this aggravates their venous disease and venous insufficiency. I have one patient that told me that she can tell when she's getting her period because her legs start to hurt, which I think is directly related to her venous disease worsening with the drop in progesterone. I recommend progesterone-only therapies. There's no risk of increased clotting with these therapies, and there's a variety of ways to treat patients in order to eliminate their period so that they can have continuous levels of progesterone throughout their cycles rather than this drop-off. I recommend pneumatic compression. This is a device where you can sort of sequentially move interstitial fluid and interstitial tissues back into the intravascular space and then back up into the pelvic veins. These are cheap. You can get them on Amazon now for $100. They work. My patients find them very useful and really have significant benefit from relief of pain and improved symptoms with them. I also recommend that my patients lean their legs up against the wall in this fashion for about 10 to 20 minutes prior to bedtime to try to help also move fluid out of the legs and lower extremities and into the IVC. This is a good method for patients to use also when they're having a flare in symptoms or if they're feeling dizzy or having excessive tachycardia, or they're in a moment where they really feel like they're going to pass out. To not just lie down, but to put their feet up is helpful. Something that's emerging, which I'm very excited about, is a fascial counterstrain technique. This is used by people in physical therapy, chiropractic. The reports to me are that they relieve compression of these veins and improve lymphatic drainage, which is exactly what this population of patients needs. Brian Tuckey is the one that developed this method, and I have heard good things. This is an emerging field in terms of management of these pathologies, which is great. So what do? I tell my patients with POTS, I explain their venous disease to them. I tell them that there's no treatment, there's no validated treatment of POTS by treating pelvic venous disease or lower extremity venous disease. Obviously, we're trying to work ultimately on randomized controlled trials in this field. I discuss the risks extensively with them. I refer them to IR and vascular surgery to get opinions from them about whether or not they feel these patients would benefit from stenting or intervention on their veins. And then we're actively enrolling patients into a prospective clinical trial for this. So many patients with POTS do well with conservative treatment. Some are extremely disabled and really can't function and can't do any kind of exercise or tolerate any medications. And in these patients, I would encourage people to evaluate them for venous disease in the lower extremities and the pelvic veins, especially if standard therapies are not helping. I just wanted to give credit to the people. They call themselves the Cutchins lab, but these are residents, med students, undergrads who have helped me extensively with this POTS registry, with creating the database that we're using for these patients. I can't thank these wonderful residents and fellows and med students enough. I'm also collaborating with people in OBGYN and in pain management clinics, in IR and in vascular to look at these patients and evaluate them and study them further. So I want to thank my nurses in clinic and my nurse practitioners in clinic. They're amazing and they're wonderful with these patients. Here's a list of references just for the talk, in case anyone wants to look any of these papers up. And that's it. I'd love to take questions.
Thank you, Alexis.
Thanks, Alexis. That is really fantastic. For years and years, this problem has sort of been something that we've hated to see because we just didn't understand it or have any real insight into it. And your work is really very exciting to me to find out that there are some underlying causes that are amenable to therapy. I just think it's really fantastic. And I don't think that a lot of people are aware of what you're doing. So I'm really excited to hear how you're going to disseminate your information.
Thanks, David. I appreciate that. I think we're working on a paper right now just as establishing the prevalence of this problem in the population of patients who have come to see me for POTS, where that data is we've almost finished tabulating all of that, meaning symptoms on presentation, comorbidities, the prevalence of pelvic disease and lower extremity venous disease in this population of patients. So that should be submitted for publication soon. You know how that goes. I don't know. What does that mean? Like 6 to 12 months, we might see a paper. But we're really working hard on this. So Dr. Clements?
Hey, so number one, I remember May Turner syndrome, and several years ago, many years ago, I was talking with one of the vascular surgeons, and he said a lot of people believe that this is not something that has clinical implications. Well, I think he was wrong. Number one. Number two, when you presented all those clinical symptoms, it reminds me of artificial intelligence. And if you plug in all those symptoms into an AI program, wherever it may be, it would probably drive it crazy. And that's why it drives us crazy, because the symptoms are so many and you can't figure out what's connected to what. So I appreciate you trying to separate that out a bit. And, you know, if we get artificial intelligence at our fingertips soon, then you can plug in those symptoms, and I'm sure it may cause a computer to explode.
I agree.
On the same note, I was going to say that with your POTS registry, you're probably going to be able to better phenotype, because, there are different subgroups within the POTS. So, I like how you focused on venous disease today. You could have probably done the same thing with MCAS or, different things. So you could really look for, just kind of like with HFpEF, we have different syndromes.
Yeah. I mean, I would say that there's clearly a difference between patients with hypertension and patients with hypotension that exists. There's no question. Yeah. It really, like, that's just one phenotype that I would say off the bat, right? There's a hyperadrenergic state. There's patients with significant venous symptoms and some patients without, who we don't even bother looking for this stuff in. And so, yes, the registry, I'm hopeful, is going to be really exciting and helpful to characterize these patients.
Yeah. What is your thought about, you talk about the age range of 14 to 45. So do you think that, some of this venous disease, what do you think is happening over time to the veins? I mean, is it that after menopause that something is also happening in terms of stiffening of the veins?
Yeah. So these patients present often around puberty. That's when they start developing symptoms of POTS. I think that the venous compression is there. I think they're born with it. I mean, in my opinion, I think that these veins just are not as sturdy as veins of normal people. But I think over time that compression develops and gets more and more severe. And I think, hypothetically, these different hits or stressors could make that venous compression worse and worse. So you have this hyperinflammatory state from a COVID infection that causes an endotheliitis that causes, scarring in that area that's compressed, or you have a stressful response to a surgery or a car accident or something like that. And then you've got this inflammatory sort of response that occurs as well. And so I think that's a multi-hit sort of process. And over time, then we develop, the symptoms that I see in these patients.
Bob has a question. Have you looked for quantitative positional changes in cardiac output by echo after stenting or other therapies?
So not yet, but and I'm eager to do that. What's been looked at in the literature and what's being most validated at this point is a carotid Doppler for stroke volume and cardiac output to look at those numbers in the supine and upright position. And we can see that in patients with chronic fatigue and with POTS, even if they don't have a tachycardic response to change in position, they will have a drop in cardiac output measured by carotid Doppler. And so it would be useful to have those measurements before and after stenting. I 100% agree that would be great.
I noticed that the patients that were stented had marked improvement in symptoms. Did those same patients have a change in their postural hypotensive response, postural heart rate response?
Yeah. So, it's varied. Obviously, there's some patients who are off all of their POTS medications post-stenting, and there's some that aren't. And I think that's the heterogeneous nature of this group of people. But overall, the exercise tolerance and their heart rate and blood pressure response has been excellent. I have patients who have been hypotensive their entire lives, and after stenting, their blood pressure is finally normal. So there seems to be a direct relationship in my mind between the venous return and their hemodynamics.
So after they get a venous stent, how long are they on antiplatelet therapy, or are they on any?
Yeah, that's a great question. There's no consensus whatsoever in this field of what to do with anticoagulation post-stenting in this population of patients. In the cardiology world, the interventional cardiologists who are placing these stents are usually using DAPT. If not DAPT, they're using anticoagulation because they're placing a stent after a thrombotic event. So they're using a DOAC plus aspirin. In patients without thrombus, those patients are getting, had been just treated with aspirin alone for a period of time, but in the era of COVID and COVID vaccines and a hyperthrombotic state, these patients have been treated for 1 to 3 months with anticoagulation and then switched to aspirin. Aspirin does not seem to be necessary long-term. It seems like most of the people I've talked to who are putting these stents in are using aspirin for a period of 6 to 12 months and then stopping it. But these patients, there is a study that shows 27 patients post iliac vein stent who went on to become pregnant. And in that study, anticoagulation was used during pregnancy. So Lovenox, which we commonly use in pregnancy, was used during pregnancy, and after pregnancy, there were no unfavorable outcomes in terms of stent thrombosis or stent compression in those patients. They all did just fine. So it's unclear.
Can I have a quick question? This is Peter Block.
Yes, go ahead.
Hi.
Can you hear me?
Yeah.
Okay, great. Alexis, tell me a little bit about inflammatory markers in these patients. Do they play into this at all because of the diffuse nature of this?
Yeah, that's a great question. There's actually there's a small paper looking at a cohort of patients with pelvic venous disease who have heightened or elevated inflammatory markers. IL-6 is very commonly raised. Many of my patients have elevated CRP or SED rate. These are the patients that go to rheumatology. Rheumatology says there's nothing I can do for you. There's nothing wrong with you, but yet they still have these very high inflammatory markers and no one knows how to treat them. The other marker that I look at is D-dimer, and these patients often have an elevated D-dimer without any evidence of a occlusive thrombus. And I think it's related to their pelvic venous disease and their coagulation, their coagulopathy that's occurring with venous stasis. I have checked CRP levels post-stenting in a lot of these patients, and the ones that I've seen, and that CRP elevation resolves, which is fascinating to me. So yeah, the inflammatory marker elevations are real and they seem to improve. Anecdotally, I mean, there's only a handful of people that we've seen, but anecdotally.
Any other questions or comments?
I just have a quick question. Alexis, it's Stefan Renfret here. I think it's it reminds me something, and I don't want to make a comparison. I just want to see how yours is a bit different. It could remind people a bit of the Zamboni story with the multiple sclerosis.
Yeah.
However, with the Zamboni study, there were not really a pathophysiologic strong explanation. He went on and treat something, but there was no real, face validity of the problem in the pathophysiology. Whereas for you, that pooling and everything makes total sense. Ultimately, what made that therapy an end was a randomized trial properly done, right?
Yeah.
So I think you're on a different path in my perspective, but ultimately beyond what you're observing in case series and obviously the potential of placebo effect and all this, I think if you could have a surrogate marker of improvement let's say in flow or something that could decrease maybe your sample size. I think I see that this is a very nice hypothesis that should be pursued.
Yeah, I appreciate that correlation. And that was one of the first things that interventional radiologists spoke to me about, actually, was that study and how he had real concerns. And I don't disagree in any way. And so I think that, yeah, the randomized controlled trial is where it needs to be. And if anyone wants to help me with that, I'd appreciate it, because I'm pretty busy. And so, but we're working on it. We're really trying to get that out there.
Okay, great. Thank you, Alexis, for that wonderful talk. You gave us lots to think about, and I will see everyone next week.
Thanks, Pooja.
The preceding program is copyrighted by Emory University.